physically it will appear the same. Okay, so how do we identify these amyloid proteins? It can be identified in the lab in 4 different ways. First, under light microscopy. Okay, it can appear as amorphous eosinophilic appearance. Okay, so this is when you stain with H&E, hematoxylin and eosin stain. Okay, what does amorphous eosinophilic means? Anyone? Anyone? You can write, or you can also verbally interact. Anyone? What does amorphous eosinophilic means?
Structureless and pink.
Okay, so it's structureless and it's pink in color. Okay, and so that is under light microscopy, H&E staining, hematoxylin and eosin staining. Okay, so you can also view the amyloid under polarized light. Okay, so you give Congo red staining, okay, and you view it under polarized microscope, and it appears as bright red fluorescence. So this is another way of identifying amyloid. Okay, so it's fluorescence in color when you see under the polarized light. Under Congo, if you stained the sample with Congo red staining. Okay, so under electron microscope, which is not regularly done in the lab, it appears as what we call fibrillar structure. Okay, so we can see later. I think I have a few slides which shows that, and it can also be viewed under X-ray diffraction, which is you can zoom further. So this fibrilla actually appears in a beta pleated sheet structure. So basically, all amyloid protein will appear this way. Okay, although it might have different chemical nature, but all of them will appear this way. Okay. All right. So this slide shows a slide of kidney. Okay, kidney specimen, which shows amorphous pinkish. Can you see my cursor? You cannot see, right? Can you see my cursor from the
No, doctor.
No,
you cannot see.
No, only a small one.
You cannot see, yeah? All right, but anyway, you have you can
We have the slides.
you have the slides. Yeah, you have the slide, but you cannot see my cursor, right? Actually, because I'm showing the amorphous. You see at the rounded area, which is actually the glomerulus, right? On the slide, the rounded part.
Prof.
Sorry?
Is it a big one?
Yeah,
the last one?
the three big rounded area, you know?
Yes.
Okay, in the middle there are 3 big areas. So in the big rounded area, the amorphous pinkish is structureless color, right? So that is actually amyloid. So that is actually glomerulus. So it's supposed to be formed by your arterioles, okay, glomerulus, but there are amyloid protein deposition, so it appears as eosinophilic, which is pinkish, amorphous structure. Okay. This is a yes.
How do you differentiate that from necrosis?
Necrosis appears, okay, so necrosis will appear more or less the same, you know, is eosinophilic, amorphous, but maybe, it is kind of difficult to differentiate between your necrosis, but if necrosis, you would expect to see more inflammatory cells surrounding it, you know, because of inflammations. Yeah, so you can see part of, you got me? Yeah, you can see that pinkish. So of course it has to be tally with the history, and you will see a lot of inflammatory cells as well. But yes, necrosis will more or less look the same. Yeah. Okay, so this is in a higher magnification, okay, also of a glomerulus. Okay, this is a view of the under polarized microscope. Okay, congruent stain, you can see the bifringent greenish color, the striking one. Okay, so this is how we confirm amyloid. So if you ask me just now, how do you differentiate it with necrosis? Okay, so in the lab, you can, if you suspect it's amyloid, you can stain it with congruent and you look under polarized microscope and it will appear as a bifringent green color. Yeah, so necrosis won't take up this stain as such. Yeah. Okay, so this is not quite clear, but if you can appreciate again, the greenish color lining the elongated structure. Okay, this is actually tubules of the kidney. Okay, so that was light microscopy as well as polarized microscope. So in electron microscope, it appears as fibrils. Okay, it is a non-branching fibrils, can be in various length, but the diameter is more or less 7.5 to 10 nanometer. Okay, so it can be either singly or it can appear as an aggregated bundles or interlocking meshworks, but it appears as fibrils, okay, which form the main part of the amyloid protein. Okay, so another component, the small components are the P components, which we can't actually see we can't appreciate much in this view. Okay, so it is it forms 5% of the amyloid component. Okay, so it has structural homologies to your C-reactive protein, but it's the different types of fibrils which of fibril protein which differentiate between different chemical structure of your amyloid. Okay, so that's okay. So as I mentioned earlier, okay, under crystallography, okay, or X-ray diffraction, you can see the fibrils in the form of beta-pleated sheet. Okay, so this beta-pleated sheet are the one that responsible for the distinctive bifringent appearance in a congruent stain. Okay, so it appears as beta-pleated sheet. Okay, this is the fibrils, non-branching aggregated fibrils. Okay, formed by beta-pleated sheet. Okay, I think this one is clearer. If you want to imagine how the fibrils is arranged, how the beta-pleated sheet is arranged. Okay, so it is arranged in such a way into fibrils protein, and the fibril will intertwine with each other. And if you can see, the red part is the part where the part of the beta-pleated sheet which take up the Congo red stain, okay, which you can see under polarized microscope giving the bifringent green color. Okay, so that's about the physical nature of the amyloid. So as I mentioned earlier, all amyloid protein, no matter what chemical structure, it will look like this physically. All right. Okay. So next we go into the chemical nature of amyloid. Okay, so the chemical nature, the different chemical nature of amyloid is depends on the different types of chemical nature of the fibril. Yeah. So the three most common form, or it is also called the major form of the amyloids, are these three types, what we call AL or amyloid light chain, AA amyloid, which is amyloid associated protein, and A beta amyloid protein. Okay, other proteins are transthyretin protein, okay, beta 2 microglobulin proteins, and amyloid, which derives from the precursor of hormones, for example, procalcitonin, proinsulin, or keratin. So there are a few organs or tissue which can produce hormone, which tend to produce amyloid protein. Okay, all right. So the main ones are these three: AL protein, as the name given, light chain protein. These are from light chain. Okay, light chain. Where can you find light chain?
Immunoglobulin.
Immunoglobulins. Okay, so light chain is part of the structure of immunoglobulins. So accumulation of light chain can form amyloid. Okay, amyloid associated protein are from inflammation. These are proteins that is secreted during inflammation. Okay, which can form amyloid associated protein. A beta amyloid proteins are from beta protein. Okay, transthyretin are actually normal proteins. Okay, beta 2 microglobulin you can see more in renal failure proteins. Okay, in a patient with renal failure. Okay, so AL amyloid light chain is made up of complete immunoglobulin light chains, or the amino terminal fragments of light chains, or both. Okay, if you can imagine your light chain structure, okay, it can be in a form of complete light chains, okay, or only the terminal fragments of the light chains, or it can be both. Okay, so where do you get this light chain? It's from beta cell, right? From your plasma cells. Okay, so when you actually get the accumulation of this protein? This is when you have monoclonal proliferation of these beta cells. Okay, for example, in multiple myeloma, when you have a monoclonal proliferation of beta cells, what does monoclonal proliferation means?
From a single cell.
Sorry?
From a single cell?
Yes, so that means from a single precursor cell. So usually, normally, our body will secrete polyclonal, so certain amount of immunoglobulins, right? Certain amount of IgG, IgM, IgA, IgD. So each immunoglobulin carries beta and kappa light chain, right? So when you have monoclonal proliferation of beta cells, that means your beta cells prone to produce only one type of immunoglobulins. Okay, and only one type of immunoglobulins which have only one type of light chains. Okay, so it's either kappa or it's either lambda. So this is what we found in multiple myeloma. All right, in AA or amyloid associated protein. Okay, so this amyloid protein comes from a precursor protein which is called serum amyloid associated protein. Okay, so this SAA protein are acute phase protein. When we say acute phase proteins, that means these proteins are secreted during inflammation, right? Okay, so this precursor protein is proteolyzed and it forms amyloid AA protein. Okay, amyloid associated proteins. Okay. The beta amyloid protein or the AB protein, it derives from precursor protein which is a transmembrane glycoprotein which is called amyloid precursor protein. Okay, so those are the three major types of amyloid protein, and others are the transthyretin transthyretins are actually the normal protein which transport your thyroxine and retinol. Okay, so this mutations of this transthyretin protein can lead to amyloid protein. Okay, beta 2 microglobulins are actually the component of MHC1. Okay, so it is secreted in large amount in a patient with renal failure. All right, so how do you classify amyloidosis? Okay, there are a few ways to classify amyloidosis. You can either classify it primary versus secondary amyloidosis, okay, or either systemic or localized. Okay, so it can be, so if we go by primary and secondary, it is more of a clinical classification, but for the purpose of this presentation, we will classify it according to its biochemical nature, okay, plus its clinical nature. So we will classify it based on systemic or localized. Okay, so you can refer to this table. Okay, so systemic amyloidosis is formed mainly by first we mentioned earlier the multiple myeloma. Okay, this is due to immunocyte dyscrasias, okay, which is can occur in multiple myeloma or any other monoclonal B cell proliferations. Okay, the most common one are multiple myeloma. You'll find later there are also other types of beta cells, monoclonal beta cell proliferation, which doesn't fit into diagnosis of multiple myeloma, but because of this monoclonal beta cell proliferations, they can form amyloidosis. Okay, so the fibroprotein that form this type of amyloidosis are your AL protein. Okay, so it is formed mainly by the immunoglobulin light chain. Okay, so apparently most of the lambda light chain. Okay, so the second type are the what we call, so the immunocyte, the multiple myeloma is classified as primary amyloidosis. Okay, primary amyloidosis, but we are not going into that type of classification. Okay, so reactive systemic amyloidosis are the amyloidosis caused by secondary to inflammation. Okay, so this caused by the AA amyloprotein. Remember, we mentioned earlier from the precursor protein of SAA, which is proteolized and formed AA protein. Okay, so this is from the second type of amyloidosis, which is reactive systemic amyloidosis. Okay, the third type, which comes under the minor protein, okay, not the major types of amyloidosis, are the hemodialysis associated amyloidosis, which formed by beta 2 microglobulin protein, okay, which forms, so this beta 2 microglobulin protein, its amyloid form or fibril form are the A beta 2 protein, okay, A beta 2 microglobulin. Okay, all right, so another type are the systemic senile amyloidosis. Okay, systemic senile amyloidosis are formed by the transthyretin protein. Okay, this I mentioned earlier a normal protein which forms a TTR protein. In its amyloid form, this transthyretin protein are called ATTR protein. Okay, so you will find later this transthyretin protein can form two types of amyloid. Okay, and its normal form, Okay, when it's accumulate, it can form systemic senile amyloidosis. Okay, which sometimes we put it under localized, because systemic senile amyloidosis mainly excreted in the heart, localized in the heart, but you can also find in other organs as well. Okay, so some books put it under localized amyloidosis. So the normal forms of transthyretin in huge amount can be excreted as ATTR fibroprotein or amyloid and form systemic senile amyloidosis. So senile because it occurs in elderly. Okay, all right. So those are the main 4 types of systemic amyloidosis. So why do we call it systemic amyloidosis? Anyone?
It does not localize. It affect the whole system.
Okay, all right, good. So because it can be excreted, it can be secreted in a few organs. Okay, so it doesn't localize into one organ. Okay, but if you have multiple myeloma, for example, your amyloid protein, you can find the amyloid protein in various organs or tissue. For example, your heart, your GIT, your respiratory tissue, your tongue, your soft tissue. Okay, so the manifestation, the clinical manifestation is more systemic. Okay, so the second types are the localized. Okay, we have senile cerebral amyloidosis, which is formed by your amyloid precursor protein, or in the febrile form, it's your AB protein. Remember, we said that the third type of your major amyloid protein, the A beta type. Okay, so this is the form which you can find in Alzheimer's disease. Okay, so it is the senile cerebral amyloidosis. Okay, another types are the type which we say is secreted from hormones. Okay, for example, calcitonin. Okay, in medullary carcinoma of the thyroid. Okay, you can find amyloids in this type of carcinoma. Okay, so the fibrin protein is in the form of a calcitonin protein. Okay, as well, you can also find this type of protein in the islet of Langerhans of your pancreas. Okay, so this is formed by the protein excreted by the islet of Langerhans, which is islet amyloid peptide. Okay, so the fibril form of this protein is called AIAPP protein. So this can be found in a type 2 diabetes patient. Okay, so those are basically the main types of your amyloidosis. Okay, all right, so as I mentioned earlier, when you say systemic amyloidosis, it means that your amyloid protein deposited in various organs and tissues. Okay, so clinically it can present with organ enlargement. Okay, where the amyloid proteins are deposited, so the organ can be enlarged, and it may be dysfunction depending on how much the amyloidosis are. Okay, so yes.
Sorry, is it important for us to know the chemically related precursor protein for each of the amyloidoses?
Okay, you have to at least know the one that is put in the table. What do you mean? So at least you should know the major one. Okay, for example, if AL amyloidosis, what are the disease related to it? What are the protein that forms it? Okay, AA amyloidosis, what are the protein that forms it, and what are the clinical conditions that you can have AA amyloidosis.
Okay, all right.
Did I answer your question? You asked, you want to know about the chemical?
I just want to know if it's significant to know the protein that causes the amyloidosis.
Only the one that is mentioned in the lecture.
Okay.
Especially the three main one. Okay, so at least I think by the end of this lecture, if you study the table, the table sort of, the table that I showed just now, okay, it sort of summarize the whole thing, you know, because there you can see the precursor protein, okay, what are the amyloid protein that is related to it, what are the clinical condition that is related to that. You got what I mean?
Okay, all right.
Okay, so at least if you study the table, that should be enough. I hope that is not too much. We are not going into a deeper chemical structure and things like that, you know, just like, you know, what AL protein, what are the precursor protein, what are the clinical condition that is related to it, at least as an overview, because later we'll talk more on the pathogenesis and the morphology and the clinical conditions. Yeah, but everything will go back to the table, you know, everything that we were going to talk about will go back to the table that I showed earlier. Okay, so causes are the one as what is put in the table. Notice at the end there is the last one, the heredofamilial amyloidosis is formed more by the ATTR protein. Okay, so which we are not going to talk so much about the heredofamilial part of the protein of amyloidosis. Okay, so for the ATTR is enough for you to know about the senile systemic amyloidosis, which is caused by the transthyretin protein. Okay, so first type, multiple myeloma. Remember, we say immunocyte dyscrasias, which can cause AL type amyloidosis. Okay, it actually only occur about 5 to 15% of patients with multiple myeloma. So not all patients with multiple myeloma will develop amyloidosis. Only from about 5 to 15% of patients with multiple myeloma. Okay. Okay, so what is multiple myeloma? It is actually malignant neoplasm. So it's a neoplasm of your beta lymphocytic lineage. Okay, so remember your beta lymphocytic lineage are your beta cell, which is plasma cell, which secretes a monoclonal type of immunoglobulins, basically. Okay, so with these monoclonal types of immunoglobulin comes a monoclonal types of light chain at the kappa of lambda. So what actually happened is because there's a lot of one type of light chain. Remember, your light chain are paired, kappa and lambda. Okay, so you will have a lot of free light chain as well. So which means light chain which cannot be associated to form your immunoglobulin. Okay, so you have to remember again your immunology, how your immunoglobulin is formed. Okay, so because of the increase in monoclonal production of certain type of light chain at the kappa of lambda, so there'll be a lot of light chain which is unpaired, okay, or cannot form the immunoglobulin. So it will be in a form of free light chain. So this light chain in a huge amount can aggregate and form the amyloid proteins. Yeah. Okay, so besides multiple myeloma, remember I said there are other forms of monoclonal proliferation of beta chain which doesn't fit into diagnosis of multiple myeloma. you will learn about this later, I think, in hematology actually. Okay, so another types are also the beta cell neoplasm, which we call Waldenstrom macroglobulinemia. So this is more of a heavy chain rather than the light chain. Okay, another types are what we call benign monoclonal gammopathy, which is characterized by low concentrations of monoclonal immunoglobulins. Okay, so all these types of immunodyscrasias are because of monoclonal proliferation of your B cells. Okay, so it will form amyloidosis, but the main one are your multiple myeloma. So systemic yes.
For the previous, is amyloid light chain, right? But it is caused by the aggregation of the beta. The previous slide, yeah, this one.
This one.
It's still amyloid light chain, right?
It's still amyloid light chain. Okay. We say the amyloid light chain comes from light chain, right? Protein light chain. So what produces this light chain are your plasma cells. So your plasma cells comes from your B cells. Okay, so it starts with proliferation of. You remember when we learned about where this the lineage of these beta cells and all that. So usually these beta cells are polyclonal. Okay, so from one type of beta cell, so it breaks into a few lineage of beta cells, so they will form different types of antibody, IgG, IgM, IgA, and so it starts from this lineage. So in this medical condition, when you have beta cell, certain type of beta cell neoplasm, so your body tend to just produce certain lineage of beta cells which only produce one type of immunoglobulin. Okay? So you have proliferation of these beta cells, but we are not. So in terms of the disease, we are talking about beta cell neoplasm. Okay? But when we talk about the formation of amyloidosis, we are talking about the protein that is caused by this neoplasm. So in this case is the monoclonal type of immunoglobulin. Okay, faham tak? Understand? So we are talking about the protein, okay, which can be formed in this type of neoplasm. So in this case, it is also amyloid AL type of amyloidosis. Okay.
All right. What do they mean by heavy chain disease?
There are certain criteria. That which at this point you don't need to know because it's more hematology. So for diagnosis of multiple myeloma or beta cell monoclonal proliferation of beta cell, there are lists of diseases under that classification. Yeah? Okay, so you have to have certain criteria in order for you to diagnose multiple myeloma or Waldenstrom macroglobulinemia. So in this case, it is like Waldenstrom is more of a heavy chain disease. Okay, but this heavy chain disease, there's also proliferation of certain light chain. Okay. You understand what I mean? So you have to read more on. We are not going to talk about this disease in this lecture. We are going to say. So you say in the immunoglobulin there's heavy chain and the light chain. So Waldenstrom macroglobulinemia, there's certain criteria that meet that it is called more of a heavy chain disease, but monoclonal heavy chain disease in this, because there is beta cell monoclonal beta cell proliferation, you will also have proliferation of monoclonal light chain, So anyway, whatever type of these immunodyscrasias, what forms the amyloids are the AL protein. Okay? So whenever there's B cell monoclonal proliferation, okay, you will have AL light chain. So you put it that way. So when you have beta cell proliferation, you will have certain type of immunoglobulins, but what we're talking about is the light chain components of it, which forms amyloidosis. Okay, so we move to the systemic amyloidosis, which is also called reactive systemic amyloidosis. Like I mentioned earlier, it is actually part of acute phase protein, which is your SAA. Okay, your SAA protein, serum amyloid associated protein. Okay, so it is excreted when there's inflammation, especially when there's chronic infection. Okay, so it occurs basically when there's inflammation, so your macrophage is stimulated, so your activated macrophage excrete your interleukin-1 and IL-6, which stimulate the excretion of acute phase protein by your liver. So this precursor protein get proteolyzed and form AA protein. Okay, so in chronic inflammation, when there's a lot of accumulation of this SAA protein, okay, so it will form aggregation and form amyloids. Okay, so in which infections, okay, not all infections you can have this amyloidosis. So previously it is associated more on TB, bronchiectasis, chronic osteomyelitis, okay, previously, okay, chronic disease such as rheumatoid arthritis, okay, but because generally there are treatment for TB and bronchiectasis and all that, it is very rare now that you can find systemic amyloidosis due to this infection. The most common now is from rheumatoid arthritis. Previously, when there's no control on your TB infection, bronchiectasis, so the top two at least remains the main cause of systemic amyloid or of the AA amyloidosis, but nowadays rheumatoid arthritis remains the most common cause of AA amyloidosis, reactive systemic amyloidosis. Okay, so another type are the hemodialysis associated amyloidosis, which are your beta-2 microglobulin. Okay, this is especially in a chronic renal failure patient. Okay, chronic renal failure patient, which is patient in a long-term hemodialysis. All right. So these patients tend to deposit beta-2 microglobulin protein. Okay, so this beta-2 microglobulin protein will turn into amyloid, will aggregate into amyloid. And last time, the hemodialysis is unable to filter this beta-2 microglobulin. So that's why last time there's a lot of this type of hemodialysis associated amyloidosis. But nowadays, a lot of our hemodialysis instrument can filter this protein out. Yeah, so there less and less happen. Okay, but we still test for beta-2 microglobulin in a patient with chronic renal failure. Okay, it can occur to up to 70% of cases of chronic renal failure. Okay, so what happened? The beta-2 microglobulin can, in its febrile form, okay, it can be deposited in your soft tissue, in your joint, your synovium, your tendon, your joint. It is associated with carpal tunnel syndrome. Okay, all right. So other types are the heredofamilial amyloidosis. So this type is not included in the table. Okay, this type is not included in the table. So because the first type of heredofamilial are the familial Mediterranean fever, you don't find it so much here in Malaysia. Yeah. Okay, so this is the amyloid form protein are the AA amyloidosis. So another one is familial amyloidotic polyneuropathies. These polyneuropathies are associated with transthyretin protein. Okay, your ATTR protein. So in this form of heredofamilial amyloidotic polyneuropathies, these are due to mutant TTR protein. Okay, so it's slightly different with the earlier we mentioned about the systemic senile amyloidosis, yeah, which is also formed by the TTR protein, but that one is more of an accumulation of normal transthyretin protein, which later aggregate and becomes amyloid. But in a familial amyloidotic polyneuropathies, this is when the transthyretin is excreted more in the nerve cell and the peripheral nerves and all that. Okay, hence it is called polyneuropathy. Okay, so this is more of a mutant TTR protein. Okay, so it is slightly different. Okay, so next we go into localized amyloidosis. This is more on a endocrine amyloidosis. For example, your medullary carcinoma. We thought about your calcitonin. Okay, calcitonin, a protein secreted by calcitonin. Okay, which can form amyloidosis. So later in endocrine, when you learn about medullary carcinoma of the thyroid, okay, one of the morphology of this medullary carcinoma, you can see amyloid proteins. Okay. Also in pancreas, okay, pancreas tend to secrete protein, the islet cell of Langerhans can secrete protein which is amyloidogenic. Okay. Another type are the senile amyloidosis. If you can remember earlier, this senile amyloidosis, there are two types. Senile amyloidosis means amyloidosis or proteins that you can find more in the elderly. As you get older, you tend to deposit more of this protein. Okay, there are two types. One are the senile cardiac protein. Okay, this is the deposition of transthyretin. I remember we say normal form of transthyretin, which is excreted in a large amount. Okay, it is in the table. It is put under systemic because it is also deposited in other tissues, but mainly it is deposited in the heart tissue, in the cardiac tissue of the elderly. Okay, so you can either put it under localized or in systemic. It doesn't matter as long as you know the systemic senile amyloidosis is also the same. Some books refer to as senile cardiac amyloidosis. So the proteins that is involved are the transthyretin protein, which is more of a normal accumulation of the normal form of the transthyretin protein, as opposed to the mutant form, which is in the hereditary, the polyneuropathy, remember? Okay, so another type of senile amyloidosis are your A beta 2 protein. Okay, another major protein, which is related to your Alzheimer's disease. Okay, so it is deposited in the brain, cerebral blood vessels, in a form of plaque, which is associated with the formation of Alzheimer's disease. Okay, so these are more localized. Okay. All right. So next, pathogenesis. Yeah. So how does this protein? Because we say, remember, we say amyloidosis. originally are the normal protein. So these are the normal proteins in a body, okay, which somehow get misfolded and become insoluble and got excreted into different tissues. Okay, so depending on what types of the major protein or the fibrillar protein, so this will form different type of chemical nature of the amyloid protein, and will be associated with different type of medical condition. Okay, so generally in pathogenesis, okay, can be due to production of abnormal amount of protein. Okay, so protein becomes abnormal amounts of protein. So that means normal protein excreted in abnormal amount or in high amount of this protein, and can aggregate and become misfolded and can be excreted as amyloid protein. Another mechanism of formations of amyloidosis are when you have normal amount of this protein, but it becomes mutated. Okay, it becomes mutated, and because of this mutation, it cannot undergo its function, or it gets misfolded, and it becomes excreted out as amyloid protein. So, for example, example of the production of increased amount of proteins are your multiple myeloma, your AL protein. Okay, we say increased production of monoclonal protein, monoclonal B lymphocyte protein. So in this case, increased amount of immunoglobulin light chains. So these immunoglobulin are the normal protein, the normal light chains protein. Okay, but usually the excess light chains, okay, will be proteolyzed and will be taken up by your macrophage and will be undergo apoptosis and all that. So it can be controlled when there are high amount of immunoglobulins. Okay, there will be limited when there are high amount of these light chains, there will be limited proteolysis. So this is when it can be misfolded and will be in the form of AL protein. Okay, you will find later, although I say these immunoglobulin light chains are normal light chains protein, but because of its high amount, sometimes it doesn't function as a normal light chain protein in terms of functions. Okay, you will learn that later in multiple myeloma in hematology. Okay, so the same with your chronic inflammation with your reactive amyloidosis. Okay, when you have chronic inflammation, your activation of macrophage, there will be increase in production of your SAA protein or your serum amyloid associated protein. Also in high amount, there will be limited proteolysis, and it will be misfolded or it will aggregate with each other, and it will form fibril AA protein. Okay, so example of mutation. Okay, so somehow they are precursor for mutation. Okay, so this mutant protein will be misfolded or undergo aggregation. Okay, and it will form amyloid protein. Example is your ATTR protein. Yeah. Okay. So again, the pathogenesis. So that just now it was a general pathogenesis. So if you go by the classification just now, okay, the immunocyte dyscrasias, we talk about excess light chain. Okay, so this excess light chain is less stable. Okay, although it's a normal light chain, but it is less stable in nature. Okay, so it formed amyloid because of its defective in degradation. Okay, defect in its proteolysis, and because it is resistant, defective degradation. So that means when it's supposed to be degraded, it cannot degrade it in a proper way. Okay, and it is resistant to complete the proteolysis of Ig. So that means although it can form immunoglobulin, there is this immunoglobulin is resistant to proteolysis. So you will have you will have accumulation of this light chain. Okay,
Doctor,
yeah.
can you repeat the explanation of defective degenerating? Because I couldn't have.
Okay, defective. So it's more or less the same as proteolysis. You know, the excess light chain get degraded. Okay, so because of its slightly different chemical nature. Okay, the degradation is defect. There is defect and its degradation. So it doesn't get degraded in a normal way. Okay, you get what I mean? So generally degradation effective. So it doesn't undergo a normal removal of this excess light chain. Okay?
Yeah, okay, thank you.
Okay, all right. So in a reactive systemic amyloidosis is the same, increased formation of your SAA. Okay, so the defect is maybe in the enzymes that is supposed to break down this SAA protein. Okay, so it is forms insoluble AA. Okay, there is also a genetically determined structural abnormality in the SAA protein, which is resistance to degradation. So we are talking about increase in SAA protein. Okay, now, so this increase in SAA protein is either this AAA protein undergo incomplete breakdown because of defective in the enzyme that's supposed to break down this protein, or the high amount of this AA protein, some are genetically abnormal in its structure. So because of this structural abnormality, okay, it is resistance to be degraded. But even if you have a normal enzymes to proteolyze it, but because it's abnormal structure, it becomes resistance. So it is more or less the same as your immunocyte dyscrasias, yeah, the mechanism. Okay, so in familial amyloidosis, we are talking about abnormal transthyretin. Okay, so because of this abnormality, it's prone to have abnormal aggregation and proteolysis. It's the same with hemodialysis. In hemodialysis, beta-2 microglobulin, we are talking about the mutation of the normal protein. Okay, mutation of your transthyretin as well as mutation of your beta-2 microglobulin. But in a beta-2 microglobulin as well, there is a large amount of these abnormal proteins, yeah, which lead to its aggregation. Okay, all right. So that was an explanation of how this amyloid protein be formed. Okay, so next few slides, we are going to talk about what are the dangers of this amyloid protein. Okay, so now you have the excretion of these abnormal proteins, these proteins in all different organs. Okay, so what damage can it done to the tissue? Okay, so these amyloids are dangerous. Okay, because it can do a few damage to the tissue. Okay, the first damage is it can cause pressure effect. Okay, so remember, it is accumulated extracellularly. Okay, so extracellular, if there's a lot of accumulation of this protein, so the cell can become compressed and it can undergo atrophy. Okay. It can also accumulate in the vessel wall, okay, and it can cause ischemia, okay, to the organ that is supplied by this vessel, and it can also cause increased permeability of the vessel. Okay, so that is the second mechanism of damage to the tissue that can be done by this amyloid protein. Amyloid protein can be toxic as well to the cell. Okay, so it can cause a direct toxicity to the cell. Okay, all right. So it is also found that the prefibrillar protein, okay, so before it becomes a complete fibrillar, okay, so it is found that the prefibrillar protein or the prefibrillar oligomers, okay, can also accumulate, and this actually more injurious to the tissue. Okay, so it can cause injury, direct toxicity to the tissue in its fibrillar form as well as in its prefibrillar form. Okay, so it is found that this prefibrillar form, okay, it is actually more injurious. Okay, so that means in the formation of the amyloid protein itself, it also imposes cytotoxic to the cell. Okay, so these are the 4 ways or 3 ways of how amyloid protein can damage the tissue. Okay, pressure effect, vessel wall damage, as well as direct toxicity. Okay. Okay, so how does it appear? Okay, so next few slides we are going to talk about how it appears grossly, microscopically. So in general, okay, grossly, okay, if you look at the organs that are affected, okay, generally the organ will appear enlarged, firm, and waxy appearance. Okay, so those are generally how grossly an organ which has accumulation of amyloidosis will look like. Okay, but you can imagine that it will take accumulation of large amount of amyloidosis in order for you to have an enlarged organ, right? Okay, so it really depends on how much amyloidosis deposits it is on that organs, but generally the organs can become enlarged, firm in nature, and it will look waxy in appearance. And if you treat this the cut surface of this organ, okay, with iodine and sulfuric acid, it will transform into blue light, blue violet. Okay, right. Microscopically, we've already talked about it. Yeah, H&E, light microscope, eosinophilic amorphous. Okay, extracellular deposits. You can give Congo light stain and look under the polarized light, and it appears as apple green birefringence, and you can look under electron microscopy, which give fibrillar appearance. Okay, so those are general morphology of any type of your amyloid. Okay. How come I cannot go to the next slide? Okay, so these are the same slides as the initial the initial one that I show you, light microscopy. Okay, amorphous eosinophilic. Okay, this under polarized. Okay, your birefringent. apple green bifringent with Congo red stain. This is also accumulation. If you can appreciate the area of amorphous eosinophilic area. Okay, also accumulation of your amyloid protein. Okay, these are the accumulation of amyloid in the liver cells. Okay, it tend to accumulate in the first. It's appear in the space of DC. Okay, you all haven't done liver, so you might not be able to appreciate a normal appearance of liver cells, but it tends to accumulate in what we call a space in between your hepatocytes, which is a space of DC, and it can grow, it can extend into the liver parenchyma, okay, and into the sinusoids. So liver cells, they are sinusoids. Okay, so it can compress the sinusoids, and it can block your biliary tree. So this is where your bile flows. Okay. Grossly, it has a quite typical appearance, different appearance in your spleen. Okay. So there are two types. Of course, we say the organ will be enlarged. This is gross. This is gross appearance. So apparently, in the spleen, there are different area of the spleen: white pulp, red pulp. Remember? Okay. So in the red pulp, it appears like zygo appearance, a nodular zygospleen. It calls the zygo appearance. Okay, so this is what you can see if the amyloid accumulation in the red pulp. Okay, so it becomes translucent waxy nodules, resemble sago grains. You know how what sago grains? Your sago?
Yeah.
Yeah. Can imagine.
Yeah.
Okay, so microscopically, this amyloid involves peri-arteriolar lymphoid shield. Okay. The sago part is the white part. Okay. The white part. Okay. So, and the ladacious. So another part, okay, is the enlargement of the tissue in form of in a cross section. It looks like a map, what we call a map-like areas resembling lard. Okay. Okay. So these are the two different appearance in of the amyloid deposited in the spleen. Okay. So the sagospleen are more nodular, and the ladacious spleen are more diffuse. Okay, diffuse deposit of the amyloid protein. Okay.
So the sago grains, are they the amyloid proteins itself? Or like
no, it is just like how it appears in the cross section.
It appears in the cross section.
In the cross section, okay. Of course, in the cross section, okay, the cross section of the nodules, okay. So it appears. Sorry, I didn't get your question.
Are the two like how they look? Is it because of how the protein deposits, or is it like that's the normal way how the spleen looks if the protein were to go to the spleen in that way. I like how is it that if one involves the white pulp and the lardaceous
Oh, okay. Okay.
Like-
So, all right. So, okay, I get what I mean. So, it is a appearance of the amyloid protein itself. Is it what you mean? Yeah. I mean, yes. Because when we do the cross section, okay, of course you can see part of the spleen as well as part of the amyloid protein. Okay. So the waxy nodules are the part of the amyloid protein. That's how it looks.
All right. Thank you, doctor.
Yeah, is the amyloid proteins. Okay. So this is the heart. Okay, if you can appreciate in the gross cut surface, the pale area, so basically the heart is enlarged. But you can see the heart is enlarged in the first one. Okay, and the cross section you can see the amyloid. If you can focus in the middle where there is a amorphous pinkish area, so that's where the amyloid protein deposited in between muscles. Okay, cardiac muscles. Okay, tongue. Okay, so your tongue can be enlarged. Okay, which is called macroglossia. So enlarged tongue. This can actually affect the speech and the swallowing of a patient with amyloidosis. Usually this can occur in AL protein depositions. Okay, this is a cross section of the tongue. Okay, this is again the kidney. Okay, kidney, if you can appreciate the first one, the Congo red stain and the polarized bright bifringent apple green appearance. Okay, and the second one is in bone marrow. Okay, bone marrow biopsy. So the one in the middle, it is given a different stain, immunoperoxidase stain. Okay, which stain which shows accumulation of monoclonal plasma cell. All right. Okay, so the second one are the how they actually in multiple myeloma, you can give the stain. All right, you can also do what we call immunohistochemistry. Okay, so you give stain that can attach to either kappa or lambda. Okay, so you can see, so when you apply this immunohistochemistry immunostain that can only stain the certain type of light chain, you can see on the third panel, you can see the staining is only of kappa light chains. Okay, only of lambda light chains. Okay, with almost no staining for kappa light chains. Okay, you can appreciate this more when you learn hematology lah. But it's just to say that on top of your polarized light microscope, we can actually do further immunohistochemistry stain to identify the type of proteins that is involved. Yeah. Okay. So clinical manifestation, okay, can vary depending on the organs that is involved and the extent of deposition of this protein in the tissue. Okay, so you can see almost in any organs. Okay, if you do microscopy histology, you can do in only you can reveals deposition in almost any organ if it's systemic. Okay, except for CNS. Okay, what happened? Sorry, I lost my slide. Kenapa?
Try
What do I
share again, Prof.
Try sharing again.
share again? Where? Where is the share button?
The arrow in the box beside the microphone icon.
Okay, sorry, I forgot. Okay. Share again. Let's see, how come I lost?
I'm so sorry, by mistake I clicked on.
Us? Okay, I can't find my. Okay, sorry. Okay, so can you all see the slides now?
Yeah.
So where were we?
The clinical manifestation.
Clinical manifestation, yeah? Okay. All right. Okay, so initial symptoms, they can be non-specific. Okay, non-specific because most of the times it's asymptomatic, but they can come up with non-specific symptoms like as fatigue and weight loss, because you can imagine the sign and symptoms are more of a mechanical effect of the protein. Okay, the pressure, how it compress on the cells. Okay, I mean, of course there's also direct toxicity. Okay, so but initially patient can be asymptomatic. Yeah. Okay, so it involves almost various cells, various tissues. Okay, as you can see in the slides, your kidney, your liver, your heart, your liver, your gastrointestinal tract. It can involve your soft tissue, your peripheral nerve, your soft tissue here. Okay, accumulation in the soft tissue. Okay, so in the various tissues in the body. Okay, so in the heart. Okay, if it accumulate in the heart, a patient may present with, of course you can have cardiomegaly, okay, but you can present with rapid and progressive heart failure, congestive heart failure, okay, as the heart become larger and not able to pump properly. Okay, so progressively it can become, you can have congestive heart failure. It may also interrupt the conduction systems on the heart because of accumulation of this protein, okay, which it can cause arrhythmias. Okay, in kidney, okay, it can obliterate the glomerulus as well as your tubules, and patient can come with so it disrupt all the filtration system, so patient can come with proteinuria, okay, up to the extent that they can come with what we call nephrotic syndrome. Okay, in most of the patient, in about 30 to 50% patient with kidney with amyloidosis in the kidney can present with nephrotic syndrome. Okay, anyone knows what nephrotic syndrome is? Anyone?
Kidney, Prof.
Yeah, kidney. Okay, so nephrotic you will learn later. You can learn more in year 2 when you do urinary. Okay, nephrotic syndromes is a medical condition when you have proteinuria, loss of protein in the urine. Okay, only have protein. Okay, so there are certain level of urine protein in which that you need to have in order for you to say this patient has nephrotic syndrome. Okay, so you have so in amyloidosis, a patient can come with nephrotic syndrome because the obliteration of the glomerulus and the filtration system, it becomes permeable to your protein, and you can lose protein from the urine. So patient can come with nephrotic syndrome. Okay, in the liver. Of course, accumulation, you can have hepatomegaly. Okay, you can have more of an obstructive nature of liver involvement. Obstructive meaning because it compresses the space in between the hepatocytes. Remember, so when you accumulate there, you will block the sinusoids. So remember, the sinusoids is where your bile is excreted from your liver into your biliary tree. So when there is obstruction of this, you can have jaundice. Okay, accumulation of your bilirubin. Okay, so when you do your liver function test, you will see there is accumulation of alkaline phosphatase. Okay, alkaline phosphatase is a I think you've learned about this in biochemistry. Liver enzymes. Okay, so remember biochemistry, got right? Alkaline phosphatase are one of the enzymes that is excreted by the liver, of course, but also by other cells. Okay, but it is one of the indicator of obstructive pattern of obstructive damage in the liver. You can see increase in ALP, alkaline phosphatase. Okay, so the damage in the liver are more of obstructive in nature. Okay, but of course, eventually, because there is direct toxicity, remember, you might have also damage to the hepatocytes as well. But the initial one is more of obstructive in nature. Okay. Okay, so massive splenic deposition, you can have functional hyposplenism. Okay, you can have a massive spleen, but it cannot undergo its splenic function. Okay, so it is called functional hyposplenism. All right. Tongue, macroglossia, it can affect speech and swallowing. Okay, so it can, so amyloid can be deposited in any part of your GIT tract. It can inflate the GIT parenchymal organ and even nerves. Okay, it can also accumulate in your vessel. Okay, which cause in your vascular wall. Yeah, and it can cause vessel fragility. This might lead to bleeding. So you can see later that patient with specialist with chemosis on the body. Okay. Peripheral neuropathy. You can have peripheral neuropathy because of accumulation in the peripheral nerve. So for example, they can come with history of carpal tunnel syndrome. Usually in a beta-2 microglobulin, the one with hemodialysis associated. Okay, you can come with carpal tunnel syndrome. Okay, so usually it's distal, systemic, and progressive. Okay, so this shows macroglossia. Okay, ecchymosis around the eyes. This is mainly in AL amyloidosis. Okay, ecchymosis around the eyes. Okay, because of the vascular fragility, you can have bleeding around the eyes. Okay, accumulation in tissue around the shoulder. Okay, this is called shoulder pad signs. Right. Okay. So that's about all. So generally, in a systemic amyloidosis, like we mentioned earlier, you can have accumulation of amyloidosis in all sorts of organs, but usually in AA you will have accumulation in organs such as liver, spleen, your kidney. Okay, where else in AL amyloidosis you can have more on the heart, your respiratory system, your GIT system, your soft tissue. Okay, but you can have it everywhere, right? Okay, so a little bit the prognosis is survival series, especially when it coexists with multiple myeloma or other disease. With multiple myeloma, your survival rate is higher. Okay. Clearly, it depends on which organ are predominantly involved. Okay, the main involve your heart. Okay, so how do you treat this? It's really good to know there are a few ways of managing amyloidosis. You can give AL, can give press the beta cell clone itself. So by suppressing it, you can suppress the production of the polyp chain. You can give alkylate with DNA. Okay, and you can give it's actually present. Okay, so for ATTR protein, okay, liver transplantation, okay, or to treat the mutant type, okay, and of course supportive care, okay, for especially for the normal. For beta microglobulin, you can do renal transplant. Okay, so I think that's about it now. 11:30. Okay. Any questions so far? Okay, so if there is no question, okay, before you go, hang on, I need to screenshot your attendance. Okay, can you just bear with me? Don't go out yet, huh?
Okay, doctor, it's okay.
Okay,
just give me.
One pin.
How do you all cope with this? It's miserable, isn't it? Miserable.
Yeah.
Okay, hang on.
Doctor, can you send us the updated slides when you're free?
Yeah, sure. I actually already put it in the team. If you can open to the uploaded. Okay. Sorry. I need to scroll and straight away. But of course, I will email to you. Yeah, you prefer it email, right? This will require.
Yeah, I think so.
You okay? This will require a few snapshot lah.
Can we open up then?
Where do I start this now? I see here. We have 120 participants. That's not bad, huh? Is there a way that we can actually capture the participants without screenshot all the okay. Oh, I probably stop recording. Do you all record this or you all record? So you all record.
Some recorded.
Because I also recorded it, but
I think it's only can one person only can record.
oh, okay.
But everyone can view the recording after that.
I see. So it is saved somewhere.
In Microsoft Stream.
I see. Understand. Oh my God. It will take a while until I can capture every single one of you. So, do you all cook?
Yeah.
Yes.
Yes.
You all
Yes.
cook, huh? That's very good. So you all get to go out and buy all the groceries.
Grab delivery.
Only
Grab,
for
ah?
family.
My father.
Oh, ada ya?
Ada Dr. Ada.
Oh, delivery the grocery?
Yes.
Okay, I can use that. Oh my God, this is taking so much of time. If you all can suggest a better way to capture this attendant.
Doctor, how about you just screenshot the ones who are not here, so at least it's...
How do I do that? How do I do that?
I'm using phone, so...
How do I capture the one who is not here? Boleh ke?
And if you use phone, you can see the...
Huh? In the phone, you can see.
Cuba tanya aku Ahmad.
Ruben, try screenshot that and send WhatsApp to Prof, because previously Hafiz can do it also, but I don't know how.
If you can do that, can somebody do that so that
I'll send to Akmal.
if you can do that, then it will save a lot of time because only a few names. Bunyi apa tu? It will save a lot of time, because inside here, oh my God, no.
Prof, I received the picture from the student. I have sent it to you.
Okay, so that you received the picture. Okay, so I don't have to print this. So you have you have the list of those who are not here. Is that correct?
Yeah.
You send it to me. Somebody, Akmal. Is that you, Akmal?
Yeah, it's me.
Okay, have you sent it to me? Let me just check. Oh, so these are those who are not here.
Yeah, but it also include the one already left the course.
Left the course. It's okay. It's okay. And some of these, I presume, also who are the one who share the laptop. Correct?
Yeah, I think so.
All right. Okay. Thank you so much. So, so we can adjourn before we start the next one. Thank you so much. The next one, what time you want to start? 12 o'clock.
I'm fine with that.
Anyone? You all want a break? Toilet break?
Yes, doctor.
Yes, doctor. 12 o'clock.
Yeah, 12 o'clock. Okay, thank you so much. Bye.
Okay, bye.
All right. Bye, doctor. Thank you very much.